Cool.
All right. Are you all ready to get started? If so, I will kick us off with a great introduction. Hello, everybody, and good afternoon. I am Michaela O'Brien. I'm the manager of the Alumni Relations team here at KUMC, and I am so glad you could all join us today and hear from our esteemed, I hear, panelists making an impact in the community. So we have a wide range of guests. Sorry, I can't speak, with alumni, students, faculty, and staff. But before I introduce our speakers, or Dr. Greiner introduces our speakers, please note that we are recording the event. I also want to encourage everyone here today to participate by entering questions in the chat. We want to know what your guys' thoughts are, what you're thinking, how you want to approach this subject. So please let us know, and please enter your questions in the chat. Feel free to say hello and introduce yourself in there as well. To go ahead and get the evening started tonight, I would like to introduce Dr. Allen Greiner. Dr. Greiner is currently a professor and vice chair of the Department of Family Medicine at the University of Kansas School of Medicine, obviously. He has a secondary appointment and teaches the MPH and MS clinical research program in the Department of Preventive Medicine and Public Health. He is a practicing family physician and is the medical officer for the Kansas City, Kansas Wyandotte County Unified Government Health Department. I'm glad I got that out. He completed an undergraduate degree in anthropology for Brown University and medical school and a family medicine residency at KU School of Medicine. In 2000, he completed a primary care research fellowship and a master's in public health degree, which is very impressive. Dr. Greiner, would you mind to go ahead and get us started by introducing everyone else today?
Absolutely. Thanks, Michaela, and thank you to the Alumni Affairs Office for putting this on, and thanks for all our attendees. As Michaela said, please throw questions, comments in the chat as we go. We'll try to jump on them. We've got a lot of questions to cover, and we've got a great group of panelists today, but we want to interact with all of you. So please, as stuff pops into your mind, put it in there, and we'll get around to it by the end, one way or the other. I think we're going to have a great interactive conversation here today. So let's just jump right in. We're going to start with Dr. Jill Peltzer. So Dr. Peltzer is currently an associate professor here at the University of Kansas School of Nursing, teaches in the PhD and DNP programs there. Her research focuses on health equity using participatory methods. Dr. Peltzer co-leads the Frontiers Clinical and Translational Science Institute's Integrating Special Populations program and really spearheads their patients and communities partnership group, which is a real key to that. She's a member of the Council for Advancement of Nursing Science, the International Philosophy of Nursing Society, the International Society of Nurses and Genetics, the Midwest Nursing Research Society, the Oncology Nursing Society, and the Sigma Theta Tau International. She received her Bachelor of Science in Nursing, her Master of Science, and Doctor of Philosophy degrees from the KU School of Nursing here. Dr. Peltzer, tell us a little bit about your work briefly, and then we'll keep moving.
Sorry, I couldn't figure out how to unmute myself. So thank you for that lovely introduction, Dr. Greiner. So I'm Jill Peltzer, and I just wanted to share very briefly kind of my clinical trajectory before I came into academia. So I, as Dr. Greiner said, I graduated with my BSN from KU in 1992 with plans to work as a labor and delivery nurse and eventually become a nurse midwife working in rural Appalachia. I never made it to L&D, instead working in ortho, neuro, and oncology. So I have a lot of experience working in the hospital, working in ambulatory care. And in 2002, I joined the Peace Corps and went to South Africa to work in HIV/AIDS. And that really sparked an interest in public health nursing and research. So eventually I sought a PhD at KU. My plan was to go back to South Africa and do research with women living with HIV. As I was continuing to work on my PhD, I was exploring the impact of HIV on Black women here in the United States. And so my research since has focused on addressing health inequities among minoritized populations using primarily qualitative methodologies and participatory methods. And so today I really see my research role as partnering with communities to answer the questions that are of greatest importance to them, sharing my skills and co-developing those processes to get to the answers. I feel strongly that research should be with and for communities rather than about them. As Dr. Greiner said, I'm part of the Frontiers CTSI, and I work with the patient and community members to bring the patient and community voice to the work of Frontiers. I am also working with a multidisciplinary team to implement a study looking at breast cancer inequities experienced by Black women. And our team includes 2 Black breast cancer survivors who are co-leading our efforts to ensure that Black women's voices are centered in the research. And our goal is to develop interventions that will address the factors that contribute to inequities along the cancer care continuum, from interpersonal relationships to policy impact. So the other theme in my research is really how we're addressing the role of racism as the root cause of so many health inequities. So I've had the opportunity to work with our Office of DEI here on campus on the task force for implementing a Center for African American Health. And I'm part of a group that's working on this educational series to look at where we have been to move forward in addressing racism and other isms to really advance health equity.
Super, thank you so much. Yes, thank you, Dr. Peltzer. And we'll hear more from Dr. Peltzer shortly. Let's move on to Dr. Ramaswamy. Dr. Ramaswamy is a professor in the Department of Population Health here at the University of Kansas School of Medicine. For the last 15 years, she's worked studying how the intersection of urban living, race, class, and gender structure affect health and social risk for women and men involved in the criminal justice system. Dr. Ramaswamy received her Master in Public Health degree from KU School of Medicine. Her bio's a little short, so I know there's more in there. She's a longtime National Institutes of Health Fund researcher. I'll turn it to her and let her tell us a little bit more about her great participatory work, and then we'll keep moving. Dr. Ramaswamy.
Thanks, Dr. Greiner. So I've been at KU for a while, 12 years in this job, and then I had my short stint as a master's student, I don't know, like 20 years ago. So I am trained as a sociologist, but I work as an applied public health researcher. I design, implement, and evaluate mostly behavioral, but sometimes systems level interventions for people who get caught up in the criminal legal system. Most of my work falls under sort of the domain of sexual health and women's health. We have a great website, which I can put in the chat, KUMC.edu/she. I don't know if that went out to everybody. And yes, as Dr. Greiner said, this work has been continuously funded by the National Institutes of Health, which to me signals both their commitment to issues of social justice and also just sort of a general awareness that people who get caught up in the system are often vulnerable to some of the most pressing health disparities. So just a word about people who get caught up in the system. So on any given day, there are about 7 million Americans with some type of criminal legal supervision. Every year, about 13 million people pass through a jail or prison in this country. As I'm sure is no surprise to many of you, the population of people with criminal legal system involvement are overwhelmingly poor, racial and ethnic minorities, undereducated, underemployed, underinsured, and of course bear the burden of multiple health problems, most notably mental health problems, complex drug problems, and trauma histories, which of course are related to infectious and chronic disease. So that's sort of the space in which we work. I train lots of people all the way from high school up until, early and mid-career faculty level. So, in addition to sort of having this research program, I'm a pretty passionate teacher and have training grants to work with high school teachers in public schools all over the state. I have diversity supplements to train staff and early stage investigators to get involved in federally funded research. I mentor early career development awards and am newly co-directing one of these early career development awards through our CTSA, our Center for Translational and Science. What does the A stand for? Advancement. Clinical and Translational Science. What's the A?
It's award, but they kind of changed it to an I for an institute, you know.
Okay, all right. CTSA, CTSI, and so that's it. And I am sort of an absent-minded professor sometimes, but ultimately really excited about the work. This is like the best job in the universe, to be with young people and to keep like innovating with new ideas and seeing them through. So I recommend the career highly to others of you.
Great, thanks, Dr. Ramaswamy. Okay, so our third panelist today is Mr. Matt Kleinmann. Mr. Kleinmann is currently a PhD candidate in architecture with a focus on public health and community development at the University of Kansas in the School of Architecture and Design. Matt uses participatory design to serve community-led initiatives in Wyandotte County, Kansas. In 2016, Matt co-founded the DOT Agency, a community-based design collaborative at KU and in Wyandotte County that was nationally recognized for its collaborative practice activities in 2017, and then internationally recognized for public scholarship in service learning in 2019. At DOT Agency, Matt's work has supported community-led efforts through mapping and storytelling, improving sidewalks, parks and trails, and increasing access to healthy food. Prior to his doctoral studies, Matt taught architecture and urban design as an adjunct professor at KU. He worked for Helix Architecture Plus Design on urban design and historic preservation projects in Kansas City, and he received his master's in urban design from Washington University over in St. Louis in 2011. He was also a member of the 2008 KU men's basketball team that won an NCAA national championship. So he's quite a rock star, and I'm super excited because we're going to start working together even more in Wyandotte County now that he's got a new position over there at our local health department. So Matt, Mr. Kleinmann, please tell us more about this great work.
Thank you, Alan, and I really appreciate the introduction. Yeah, I mean, I'm sort of in the company of the people I look up to, so I'm just honored to be here on the panel. I think in the world of architecture that I'm coming out of, it was heavily influenced by my time at University of Kansas, especially playing basketball, because learning about architecture while playing basketball, I thought someday I'd be building stadiums. I had an opportunity to intern at a variety of Kansas City architecture firms that were famous for building NFL and Super Bowl and World Cup stadiums. And it wasn't until I was in graduate school that I learned that to build a stadium, you usually have to tear down a neighborhood. And I thought, man, that's really terrible. And so I thought, I don't want to do that. And I came back to Kansas City and I started working as a firm. And sure enough, every large project, you're usually displacing a community that already exists if you're working in an urban context. And when you ask the neighborhood what they wanted to do with $250 million of taxpayer funded money, it was rarely to build a stadium that got used 8 times a year. They wanted safe, affordable housing and access to grocery stores so their kids could, grow up strong and healthy. And they wanted neighborhoods that took care of their basic needs, and they didn't feel like they were disinvested for decades. And so a lot of the work that I've been a part of, unfortunately, we don't have the lineage of participatory design in our academic practice and in our ethos. Architecture has often been a client-serviced model. And so my dissertation and research I've done, I previously worked at Children's Mercy, is implementing models of shared governance so that communities are making decisions and then facilitating those decision-making moments through participatory design, using methods of design to make the process of making decisions more tangible, and using storytelling and kind of a urban design scope to envision what communities want to see in a way that actually can compete when it comes time to fund projects to get them built in the real world. So making tangible improvements helps to build trust with communities. And I think if, a lot of the folks on this call and our networks, the more we look at the social determinants of health and how the built environment impacts that, I think I learned from my colleague at KU Med, Nikki Nolan, that public health often teaches the challenges of the world, and architecture is really good at problem solving, but how do we get those two to talk together? And so I've really enjoyed learning from my colleagues in public health about how the built environment impacts health, but then how do we turn that around and organize a community to make decisions for themselves so that they can invest the resources in the amenities that improve their quality of life, so we don't see health disparities as great as 24 years like we do in Wyandotte County.
Great. Thanks so much, Matt. That's really exciting. And thanks to all of you for being here. So we're going to go through a list of questions, and kind of the initial set will we'll ask for an answer from each of you if you have one to throw in there, and then we'll kind of get to a few individual questions at the end. But again, for the attendees and the participants that are here, please put comments or questions in the chat as we go, and we can address them as we're moving, or get them at the end, and we'll have time then at the end also for questions. So please don't be shy. Jump in there and throw things at us as we go. So the first one is really kind of a career question. So for each of you, what's behind the passion? What really kickstarted things in terms of your passion and your drive to take you down this career path? I think we heard a little bit about that, from you, but maybe you could talk a little deeper about where it comes from. Dr. Peltzer?
So I decided that I wanted to be a nurse when I was 17. I was in a physiology course, and I had an epiphany, and I have never looked back. For a while, after I finished my PhD, I kind of wondered, like, I would see nurses who went right from their BSN to PhD, and I thought, oh, if I had done that, I would have so many more years for research. And then I realized, but my career and practice has been so fulfilling, and it's informed who I am as a researcher, and it's informed who I am as an educator. One of the things I've become really passionate about through the work I did in South Africa, and then as I was starting my PhD program and I was a graduate teaching assistant, is what we're teaching students, and at what point in the nursing curriculum are we teaching students. So when I was in my nursing program, I don't remember learning about the social determinants of health. All I really knew coming out of the program in that relationship with this person was in my setting in the hospital, and not paying as much attention to where that person came from and where they were going. And so I really want to make sure our students at our BSN to PhD level have a population health mindset. And that really drives how I think about teaching and what I teach, and really understanding the drivers of health and health inequities. I think I went off on a little tangent, but there it is.
It's all connected. We know that. So Dr. Ramaswamy, tell us about your career path and the passion. Where do you think it comes from for you?
Well, I think so much of this is family history and context. So I'm an Indian American person. I was raised in Mississippi, of all places. And we lived in one of those towns that had an academy, an all-white school that was set up during desegregation. And so I just sort of grew up really understanding what segregation and racism looks like when it's pretty in your face. And so that sort of context and that history was kind of ever present. And I think I probably have looked for opportunities, whether it's through service work or internships or research, that have in some way or another addressed the sort of intersections of race, class, and gender. In college, this is very particular, but I did a project on child sexuality and was sort of very interested in young people as sexual beings. And to be honest, I think it was that initial spark, that sort of intellectual spark, that sort of set the tone for a very long career now in sexual health and women's health. It turned out that I had a set of skills to do research. And so I just always looked for jobs and training that would help me utilize those skills. And I think sort of on the back end of this career, not on the back end of the career, I'm still relatively young, but it feels like, I'm like senior in my field. Now I'm able to sort of make some of those connections between what was sort of intellectually interesting, what is about history and context. I also have a certain level of political engagement in the work I do. So when I sort of had that interest in child sexuality, my first thought was, oh my God, I'm going to go to law school and I'm going to become a child advocate. And, I ended up not choosing that path. But I think that sort of commitment to issues of social justice and getting out in the field, registering people to vote, activating voters, being politically engaged, supporting candidates, paying attention, reading the news, at whatever sort of level we can manage in these difficult times, has always been sort of an important part of my career, and also maintaining that sense of passion and engagement and investment in people and myself, frankly.
Yep, makes sense. And Matt, you talked about it a little bit, but maybe you can elaborate on kind of where things started for you and what's driving it all.
Sure. I could probably tell a couple small stories and just thread them together. In high school, I focused on basketball, and I had an arts teacher who I was really passionate about art in school. And he said, Matt, you're not a very good artist, but maybe you'd be a good architect. And so I dual enrolled at KU in architecture and art, and an art teacher at KU gave me a really tough time. And so I dropped art and I stuck with architecture. And it wasn't until my 5th year, I had a professor, great professor, Gaylord Richardson, and we were designing this big project down on the river market at KCMO. And I was really concerned about how people would walk to it and bike to it and get there by car and transit. And he said, Matt, it's just a building. Don't worry about the city. And I remember thinking, I really should worry about the city, because I felt really drawn to that. I felt like there was like this, almost like architecture wasn't right for me either. I wasn't going to be a good architect. So I moved into urban design. And when I was there, I had another mentor, a gentleman by the name of Theaster Gates, who is an urban planner and an artist in the south side of Chicago, who created a foundation called the Rebuild Foundation, working in the North St. Louis area, not far from Ferguson. This is pre-Ferguson. And so we were doing work in the Northeast area, and he one day stepped out on his patio porch, and he kind of said, y'all, you better get inside or you're going to get shot. And we were all a bunch of white students walking in scared to death. And he kind of just said, I want you to understand what kind of power and privilege you have as attorneys, as law students, as social workers, as architects, as urban planners, that you all only show up when there's grant funding or a ribbon cutting ceremony. You're not here in the communities day in and day out working with us to improve these communities. And it struck a chord in me that I thought, I can't go back to practice. I can't go back to serving clients and drawing bathroom door details for more than I make in a month. And those bathroom door handles are serving a type of system that, oppresses people. And so I left architecture years later with that in mind, thinking, how do I serve communities? And public interest design drew me in early on. My wife was born and immigrated from India. And so I was having conversations with her about, the role of architecture and design and how community engagement is really not enough, frankly, in a lot of the work that we do. And public interest design was, this new avant-garde, post-recession world of architects serving communities, but they were still doing what they always did. They were still drawing what they wanted to draw. They were still imposing their will, and there was no participation. And the more I looked into it, especially with dot agency, it's this idea of taking spatial agency, where oftentimes communities have a desire for something, but for a variety of technical reasons, the city or a developer or whomever says no. And working with those communities as an advocate, as an ally, sometimes as an accomplice, to actually be the design service that they need to draw plans, to build power, to tell stories, to propose the projects that have a sophistication to them that can compete to actually get to yes, and adapting along the way to jump through the hoops that a city or a planning department might say no for X, Y, and Z. Well, when you're a designer who serves a community, you can actually address that. The challenge is, how do you pay for it, right? And so I feel oftentimes like I'm in a career field that doesn't exist yet. So on my LinkedIn profile, it says community health designer. Nobody has a community health design position anywhere, not a school, not a health department, no one. But that's the work I feel drawn to do. So my career has kind of taken an assortment of skills, and I build them interchangeably as the need arises based on the desire that the community partners have. So I'll share in the chat a little bit of it, but I still have with me as a kid that artistic mindset. So I still bring cameras out to communities, and I work with community partners to help tell stories, because it kind of scratches that itch to tell stories and visualize it in a beautiful way. But it also comes back to, how do we install park benches that can get CDC funded? It also comes back to, how do we build grocery stores that provide dignity, so that it's not just about solving the food desert and being a white savior in that process, but actually letting the community say, here's what we want, and letting that decision-making process come through to the built environment. So it's been a wild journey, and I know I'm at the early stage of it. So at some point, Jill and Meg, I might be calling you guys for a job down the road, but right now, Alan, I'm really excited to work with you.
Well, I just put in the chat that you're such a star, and let me know whenever I can help you with your career or community work.
I appreciate it. And I should say, much of what I have been a part of, I cannot take ownership or authorship for, because, and I know Megan and Jill and Alan feel the same way. So much of this work is community led and driven that it's almost unfair that we're on this panel, even with all the other KU alumni that we work with, because it is oftentimes our community partners who are leading the way, and they deserve as much, if not more, support. Sometimes we're just fortunate to be in the academic circle to share stories.
Couldn't agree with you more.
Yep, couldn't agree more, and super exciting, really good stuff. All right, sorry, we got sirens around here. So next kind of couple questions, we're going to talk about community change. It's a little shift here, but from your perspective, maybe if you were going to give advice, how can folks successfully execute change in communities, or improvement that that the community really thinks is improvement? Maybe you could talk about things you've seen happen there, and what you think needs to happen. Dr. Peltzer, you want to go first?
Sure. And I am going to keep it really brief, is listen to the community. I think Matt touched on it when you talked about the white saviorism. And I think that there is kind of a mindset that I know we're definitely shifting away from on the medical center campus, and the global health work that we do, and what global health means. And global health is local health. Local health is global health, and getting away from this idea of medical missions. But there are still a lot of people who I know it's driven by altruism, have this idea that they're going to go in and save a community. And so we have to decolonize that thinking and really listen to what the community wants, what the community needs, and how can we partner, if the community wants to partner with us, in addressing those needs. So as a researcher and as a nurse, what are the skills that I can bring? Do I have a role in this collaboration? If I do, what are the skills I can bring as a partner or as a consultant, but not as the person leading that initiative? I really think it needs to be community driven.
That's great. So listening to the community, that's such an important message, I think, for all of us to keep coming back to, right? You guys all do it fantastic, but so many times we lose it, especially in the culture of biomedicine and healthcare delivery. We lose it. So Dr. Ramaswamy, what do you think are some of the key factors of helping make change happen?
So I guess I'll sort of talk about the macro level a little bit, and maybe sort of the mid-level. I think voter activation is so important. We've been through a few really tough elections, and I see that there is lots of reason to still be disillusioned. Nevertheless, we talk to the people we work with and develop interventions for all the time about the importance of voting and political engagement, even just as part of the process of doing health interventions or high school education. I think just sort of understanding that you have a voice and this is your right, and people are very confused about what their rights are, especially when it comes to criminal legal system involvement. And getting people to sort of appreciate that, yeah, they have a stake in this. And that happens sort of at the national level, at the state level, and at the local level. I think that local politicians, maybe as difficult as they are to work with, are, they have their ears to the ground, and it's in their interest to pay attention to what their constituents have to say. And I think the extent to which we can leverage those relationships, forge new ones, and get people, in the streets on board with that kind of engagement, I think sort of serves civil society. So that's sort of at the macro level. At the mid-range level, I'm primarily a researcher, and I'm not technically a community-based researcher. Yes, I work in communities, but I also work in really tough, sometimes awful systems, right? Like the legal system, the prison system, the jail system. And I think one of the important lessons from my research is that if you ask and someone says no, you ask a new way, and you keep asking until you get to a yes. I know, as Matthew said, I'm operating from a place of extreme privilege. But I think that there's an important lesson there for those of us who are working in the field. There's no shame in, like leveraging our own power and asking for things to happen, even when we're working with systems that are difficult. And that's certainly how we've tried to force changes in criminal justice policy, in COVID policy and procedure at the jails, which has been extremely important recently, in vaccine policy. Sometimes just asking and using your power can be really effective. And I guess I would say the third thing, is to sort of get out of our comfort zone as people who are sort of trapped in an ivory tower or trap ourselves in the ivory tower, and to hit the streets. My team and I, one of our favorite things to do is to just drive along, see participants, see women in their homes, not so much in COVID anymore, but to just really be out there in the community all the time. It's so easy to just go to your office and sit and never see anybody. And now we're all trapped in our homes still. But the moment sort of we can get out there, and we have been sneaking out a little bit, I think just showing up is critical.
That's great. A lot of great tips in there. We could have a little white paper out of that a little bit. Matt, what do you think? What do you think are some of the key factors in changing things, improving things?
Sure. So I should acknowledge that a lot of the work that agency does stands on the shoulders of public health folks who've been doing it far longer than we have. And so our role has really been translating that into the practice of the built environment. And what kind of got me started in that process was with my colleagues, Shannon, Chris, and Niels Gore, but Shannon and I especially, we translated the CSTA's principles of community engagement that were published in 2012 into what does that mean for architects? And for us, it was really about challenging our ethos about, well, who's the designer, who has ownership? How do you engage with the community? How do you build it in a way that's reciprocal and iterative, so that you're not trying to solve the world's problems, but you're making tangible momentum and building with trust with partners along the way? And so that was kind of an early entry point for me, that, writing that article and really reflecting about how that work carries through in the work of that agency. But, most recently, the focus of my dissertation is on this exact question. And so through that process, working with residents in Kansas City, Kansas, to build a mobile market community council, we did, interviews with all the participants and had a lot of data to reflect on. And from that, there was kind of 5 principles that we kind of framed based on what people were saying. And the first one was to build community first. A lot of folks worry about building trust, and trust takes time. But building community is, to Megha's point, just being present with people, having, getting to meet with them, being empathetic, listening, really getting to know them in their spaces, and worrying about their concerns before you try to extract your own. And so oftentimes trying to making change happen with the community, those communities that have been there for a long time, they know what change has and hasn't been there. And so if you come in with this new perspective, being prepared to lay that down for a little bit and just be a part of the community with your community, and not trying to treat them like they're a monolithic other entity. For us, it's also been about layering participation. So much of the work we do oftentimes has agendas and grants and deliverables, but if you let the community help create those and layer how you get there, that I think builds trust and partnership as well. Making sure that you're super clear on roles and guidelines. Accountability is huge in this work. So if somebody feels like they've been left out of something, that can undermine the entire process. And so being extremely transparent in this work is really important. We've also found that it's important to adapt and update things as you go. Sometimes we set the scope for 2 to 5 years based on a variety of factors. And if you don't have the flexibility to update that, sometimes after a couple of years of doing the same thing and it's not working, you burn people out. People don't want to come anymore. You start to wonder what's going on. From a design perspective, you would iterate, you'd improve, you'd make changes, you make tweaks, and that ethos I think helps communities as well, because things change. COVID changed. How many grants and public health projects pre-COVID had to change because of the circumstances? Well, that could apply to almost everything that we do, and being responsive in that way, I think actually it really helps our community partners move the needle a little bit more. And the last thing is, just as an architect, you got to target things that are concrete. Having things that are tangible really helps, even if it's just a policy change. And that gets to Kim's question in the chat, but having something that people can hold in their own hands, that they can say, hey, we did this. I think it does something at a visceral level that builds momentum with community partners when they know that their impact is felt and it's real. And sometimes we get in our own bubbles where we can have conversations and you can walk away and go, well, what changed? I think even if it's the translation of what folks are saying into something that can be shared and it's a tangible thing, I think is an easy way to support community efforts, because sometimes these systemic changes are because of decades of disinvestment. And so if you're not changing anything for, within a 1 to 2 month timeline, people might feel like it's not going anywhere. Well, 2 years later, what do you have to show? And so I think building towards tangible goals early as part of the process helps sustain the effort for what might take multiple years or even decades to undo the damage that has been done. And I'll just go back to one last thing. This isn't in my research, but it's very much in what Megha said earlier. I think being aware of politics, and not big P politics, but local politics, being aware of local relationships and understanding that, like, from my perspective, our built environment, our public health is designed for. There are systems that have been created, and the people in charge of those systems can be engaged with, and they can be talked to, and they can be brought to community meetings that you're a part of. And so, like, being aware that, like, having a local approach towards building power with your community partners can actually, it might not get you a win in the first couple of years of a grant project, but you build the capacity, and especially working with youth, you're building the capacity for long-term success.
That's great stuff. Really great stuff. You mentioned a question we've got in the chat. I'm just going to jump right to it. Our good friend Kim Hewitt is asking about policy stuff. So I'd love to hear what each of you think about how do we communicate that, that expressed community need, or some of that community input into policy that can affect change. You're hinting at it, Matt, with the stuff about local politics, but I'd be curious to hear what each of you think about how we can do that and do that effectively. Dr. Peltzer, thoughts on that?
I think I'm going to defer right now and listen to Dr. Ramaswamy and Dr. Kleinmann, because it's a question I don't think I have a good answer. I feel like that's a weak area for me, and probably for a lot of nurse researchers, I'm not going to say others, is how do we translate research into policy? So it's really important. I just would like more skill in being able to do that. So I'm turning it over.
Okay.
I think you're not alone. I need more skills in policy and sort of, action as well. I keep saying my 5-year goal is to have policy impact, and 5 years keeps happening, and there still hasn't been policy impact. I mean, I guess, like, if I think about the issues that are the most critical to my work: mass incarceration, women's health, and women's rights. The best thing that we have been able to do, or I guess the most effective thing, is to stay politically engaged. So our critical health literacy interventions talk a lot about the relationship between voting and Medicaid policy and state level politics and cancer screening, right, which is our primary outcome, as a way to get women excited and, feel like they have a role in voting in a way that sort of benefits expansion of Medicaid or their access to cancer screening. And sort of, because I have all of this privilege, I have been really strategic about engaging with organizations, engaging with local and state politicians around like, can I be, and also engaging with the ACLU, the American Civil Liberties Union. Can I be a resource? Can I be an expert? Can I provide expert testimony? And have done all of those things, either to break individuals out of jail in COVID or to sort of testify to enact greater policy change. I am partnered with an ER physician who is, you know, sort of outspoken, both in terms of like gun rights, but also about gun safety, and just sort of like encouraging people in positions of power to engage with the local media and your local stakeholders to like make a change happen. And so I guess media engagement is the second part of that. Like, how do you become really savvy? And sometimes paying attention to what your institution is telling you and sometimes doing your own thing. It's a fine balance to really like, you know, use your expertise and get it out there. Because I think the challenge of being an academic is that we're all very smart, but we're like trapped in a bird cage. And that makes it hard to really have policy influence. So in my old age, I'm trying to play by the rules and engage with our awesome legislative liaison, who is truly awesome, to sort of brainstorm ways to engage policymakers, and to, you know, to also engage in our media department to figure out, all right, how can we do press releases? How can we bring issues to light, even if they're really tricky issues, just pushing and pushing and pushing, you know, until you can sort of see change happen. So I guess, you know, again, political action, media engagement.
That's great. Matt, give us your thoughts. You've talked about it a little too already, but other ideas.
So Megha touched on the idea of, you know, for folks that are, you know, PhDs and multiple letters behind their name, there's a guy named David Bohm who wrote about this concept of on dialogue. And he talked about this idea that we go up the genius mountain and we get to the pinnacle of our careers, and we can actually have really great conversations. Even if I know nothing about public health, I can talk as an architect with somebody who knows a lot about it because we have a similar language. But oftentimes what we don't do is go back down the mountain. And so I think the first step in making policy change is translation. I think it's translating it into something that you can explain to your grandparent or your child so that they can truly understand what's going on, and not doing it with some sort of, you know, paternal approach, but like just making things accessible. That's so much of the challenge we see in public health is access. And that includes access of policy language. The other part of it that I've experienced is drawing it. When you can translate a policy into how it shapes someone's life in a way that's illustrative, and then you start moving the pieces around, now you're moving policy around. And so like we did that with our mobile market process early on, because the Wyandotte County had a zoning ordinance that said mobile markets can't exist outside of commercial properties. Well, we engaged the community. We had 142 locations and only like 12% of the locations were in commercially zoned properties. We had evidence to change a policy, but it took us literally drawing it with our community partners, expressing where they wanted it to go. So we could tell them, well, your policy is inadequate. And it's not us saying that, that's your constituents, that's your community saying that. And so also like really knowing the policy is a good thing, you know, being able to read it and know like which words can be changed and how to, you know, get into the wordsmithing. That takes skill and time, but like, that's where it happens. We've had failures in policy. We tried to change a policy where in Wyandotte County, communities submit park ideas because we kept seeing again and again, parks were looked at as equal. Wyandotte County Park has 500 people living within a half mile. Jersey Creek Park has 20,000 people living within a half mile. But at the drop of a hat, Wyandotte County Park gets $2 million and Jersey Creek gets nothing. Well, we had to draw that relationship of how many people live within walking distance to actually get them to be aware that, oh, we need a different process. We need an internal policy. The problem is that they didn't commit the resources to keep the staff to maintain the policy. So like there are failures as well as successes in policy work. But what hasn't been a failure is we built relationships with the people that are in those positions. And now one of the person that drafted the policy with us is now the head of that entire department. And so like we can go back to them and say, hey, can we bring that policy back to the forefront and actually get it to work this time? You were, you know, at a different level now, but we have a relationship and we can bring that back. And I think that I'm excited about that because like the Robert Wood Johnson Foundation has a $7 million grant out there for park equity to change the policies of parks and how systems are addressing it. I mean, the social determinants of health is something I've learned, but I've also learned about the political determinants of health. And so I think as people in community and public health, recognizing that those policies shape whether or not there's a drinking fountain at Jersey Creek. It'd be nice to say, hey, we should have a policy to support people living their best healthy lifestyles.
That's great stuff. I think it's really exciting, and we're going to talk now a little bit about COVID. We've kind of all hinted at it a little bit, but I've certainly seen a lot of crazy rapid policy stuff happening with COVID, and I think as some of you guys know, and now Matt's jumping right into the middle of it, we've really tried in Wyandotte to put community input at the forefront of policy stuff. And the only thing that happened with COVID for us is that we were just lucky that it was all happening so fast that we could infuse that almost before people could figure out what the heck we were doing. Of course, then the state legislators start changing laws, but that's a story for another time that we can talk about. So let's get into some COVID stuff, because I think it's kind of instructive, and I know it's impacted all of your work and the communities that you are working with. So it's definitely shifted public health in different ways. What are your thoughts about how COVID is changing the landscape in the different communities you work in, how public health's playing a role in that or dropping the ball in that, and how we can get communities participating more in that process and influencing them more. Dr. Peltzer, thoughts on that?
So I think I'm going to talk a little bit from maybe a nursing perspective, because most of our students in baccalaureate programs across the United States tend to go into the acute care setting upon graduation. And for a long time, we've always had this kind of mindset that you had to have 2 years on the med-surg unit before you could go into a specialty, including public health. And we have seen a real shift in that kind of thinking, and also have seen more new grads go into public health now because of the pandemic, which is great because we have a tremendous shortage of public health nurses. And we need more nurses going into public health and into community settings. The acute care setting is great, but it's not the end all be all in nursing. And so having more nurses start immediately in their careers in a community-based setting or public health is good, I think, for the communities. One of the things I think that the pandemic has amplified, perhaps for everyone, is the lack of funding that goes into public health. I can't remember the percent, but it's so small compared to funding every place else in healthcare. And that was really demonstrated by the call for nurses and physicians and other health providers and community members to volunteer for testing sites, to volunteer with the vaccine rollout, because there has not been an investment in public health the way there has been in other areas. We would never ask a hospital nurse or a physician to volunteer to do some kind of procedure. Insurance is going to pay for that, or the hospital is going to pay for that. Yet we had to mobilize quickly volunteers because we just haven't had the infrastructure that's needed in public health. We don't put the resources needed at primary prevention and health promotion. And I think that the pandemic really amplified that.
So there's no
question jump in there.
That the pandemic has had a tremendous impact on the system of mass incarceration in this country and the 13 million people who move through jails and prisons. So there's like a major negative, but also a couple of positives. So the major negative is that 80% of the largest COVID outbreaks in this country happened in a jail or prison in the US. The positive is that criminal legal systems worked really hard and really fast to decarcerate, which is the process of letting low-level offenders, nonviolent offenders, people who are, awaiting parole to get out and get back into their communities, which of course is the goal for those of us who are working in the field. So in Wyandotte County alone, there was a 25% reduction in the inmate capacity pretty early on in the pandemic. So while those of us working in the field were constantly on the phone with sheriffs, wardens, mayors, legislators, whoever we could find to say, please implement these protocols around hand washing, social distancing, masking, folks in the system, prosecutors, sheriffs, were all working behind the scenes to decarcerate pretty quickly. And that wasn't probably for reasons of public health or even reasons of, the inequities and the discriminatory practices of mass incarceration. It was a practical reality. So it was this sort of happy unintended consequence. And also sort of showed the world that it's possible to decarcerate rapidly without a huge community impact. So that's sort of the positive. Now, the moment we sort of, the vaccine was sort of coming down, we had to pivot from here are all the procedures you need for sort of decarceration and safety to how do we get people to take vaccine? And that's been, again, sort of hit or miss. Again, on the phone constantly with wardens and sheriffs and legislators and mayors and health departments to sort of say, how can we create these connections between the criminal legal facility and the health department facility to offer vaccine, to get inmates interested in vaccine, to answer questions. And we've sort of seen that, at least in the state of Kansas, it looks like between 30 and 50% of people, inmates have taken vaccine. And the percentage of correctional officers is actually lower than that. There are some jurisdictions in Colorado and Massachusetts where something like 80% of the inmate population is vaccinated. Again, lower for correctional officers. And it's a combination of a sort of systems level problem. Do they have the systems in place to store vaccine, to offer vaccine, to talk to inmates? And then, of course, the sort of usual stuff that's happening in this country around trust of institutions, which is critical, right? You can imagine being incarcerated with no rights and not trusting the systems that are telling you about a vaccine that frankly, we don't know a whole lot about unless you've been paying attention, a lot of attention. And if you're incarcerated, you can't pay attention because there is not that kind of access to information. And so it's been a sort of complex problem to address, especially since most facilities in this country are still on lockdown. And I think, for those of us working in the field, burnout is real. Correctional officers are burned out. Health department people are burned out. The nurses who are offering vaccine are burned out. Wardens and sheriffs are most definitely burned out. I'm burned out. And sort of keeping up to date about what's happening and what systems are in place and how do we improve those systems? How do we routinize those systems has been a real challenge. But it is sort of a plus minus. I think that we're going to learn so much from this pandemic about every aspect of life. But as it relates to mass incarceration, I think it's really going to point to some interesting opportunities for doing really good policy work and really good public health work.
Yeah, great. Matt, thoughts on the pandemic?
Sure, I'll try to keep it brief. I mean, from two things I've been most engaged with has been working with young people to restore vacant lots and parks, and working with the community to bring fresh food access through the Dot Mobile Grocer. And one of the things we learned in the Dot Mobile Grocer, we handed out about 16,500 USDA food boxes from October of last year to May of this year. And of those, we included small surveys that people could take. And we saw that before the pandemic, Wyandotte County's food insecurity rate, which is referencing the concern that you don't have enough money to buy your next meal. Wyandotte County as a whole was looking at 16%. Post-pandemic, certain agencies are looking at 21%. But what we saw was 86%. 86% of the community we were serving had reported not being able to have enough food money to buy their next meal. And I think what we're seeing because of not just the pandemic, but the historic racism in communities is the longstanding epidemic has led to an inequitable condition that the poverty just exacerbated. We don't have a homeless shelter in Wyandotte County. We don't have, basic support structures for a lot of people who are living paycheck to paycheck and on the edge. And when they lost their jobs, their families went hungry. And so I think the pandemic has only widened that division. And I think that's part of the reason I'm excited to work with the Health Equity Task Force, to just be aware, like as we look to reinvest, those are also policy decisions. Those are decisions that I think Megha's comment about the kind of happy unintended consequences. I mean, I know just as a small example, in Wyandotte County and a lot of places around the country, you couldn't do outside seating because for some reason policies just said you couldn't do it. And all of a sudden everyone's doing it. So, I think there's an idea that like we can be more bold in proposing the things that communities really need to survive and also make our lives all around better. But I think it's worth recognizing that those that are most on the margins are the ones that are being most impacted. And I think addressing poverty is going to only become more critically important going forward in the work that we're all doing collectively, because it is an underlying factor in every health disparity that we're seeing. And so I think that's something that the pandemic has created opportunities to address it when we say, well, we can change things. We did then, we didn't have to go through all the hoops you asked us before, but now let's get to the issues that are really impacting people. And I think that's something that I think we're going to see for years to come is a challenge.
Yeah, that's I certainly hope we've learned some lessons that we can keep utilizing, to make things happen quickly and address needs as we go. So I'm gonna go a little off script. We want questions. So if you're participating, if you're out there, throw some stuff in the chat, raise your hand. If we're missing any questions, Michaela will let us know. We want to hit those, but I think we're gonna do one more round robin and kind of have each of you talk. I think it'd be great to have you talk about, what we can do to get more people like you coming along and in the pipeline. I mean, for each of you, you've got your own discipline. In some cases, like Matt, it's like you're creating a new discipline almost. But we need these things. I know all of you work with a lot of students, and you're attracting students who see this great, energetic, impactful work happening. But what can we do as a university to keep bringing more of them to the fold and then disseminate it even more broadly to have impact? Dr. Peltzer, talk about nursing researchers, public health nursing, community nursing. I'd love to hear your thoughts on that.
Well, I would love to change the way we teach nursing. We start with a biomedical model. Students go into clinical in the hospital. I would love to see us start with a population health focus and a community focus, and health promotion using a health and all policies model. Maybe we have students who never go into the hospital. Students may not ever start an IV, but they are learning about the upstream impact. They're learning about the root causes. So, Matt was talking about food insecurity. I just went on a tour with a student at Save Inc., which provides housing for individuals with HIV and mental illness. And they have a housing first policy. Until someone has safe housing, we can't address some of the other issues. That students should have that kind of mindset when they're thinking about health for individuals, families, and communities. And I think if we shift the way we're educating students, not just in nursing, I think all health professions, to think about the root causes and how do we address the root causes, we can prevent a lot of the health inequities and even a lot of the chronic disease.
Super. Dr. Ramaswamy, how do we get more people doing what you're doing?
So I've been engaged for a long time in sort of working with, designing, getting funding for pipeline programs to actually get high school students interested in health disparities and public health careers. And one of the strategies that we've relied on for a long time is to get kids excited about, to say, hey, what are the big issues in your community and what matters? That way you sort of get students invested in the problems that they've identified. So it's this like traditional community-based research stuff, but getting young people and students in particular to sort of identify the public health problems, identify the public health solutions, to work with their teachers and faculty like us to sort of understand, well, who are the connections in the community to actually make change. And the hope, of course, is that those students then go to pursue STEM education in college and then maybe come back to us down the line for public health training. Now, I wish I could remember our outcomes from this last big project we ran, but I want to say that people who participated in our program that was community-centered and student-driven, that they were significantly more likely to complete their health science pathway program than students who didn't have exposure. But that's certainly the principle by which we operate, is that if you can get kids excited about their communities, they're going to be more invested. So in this new project I have for engaging high school students, we're using a similar model. This time, though, we're trying to facilitate connections between the health system industry, public schools, and universities, so that students are sort of wrapped up in a triangle of workforce and education and their own public health, public school embeddedness, to sort of understand, well, what are the ways they can get trained to then compete in a workforce that's actually in their community. You know, and we're making that location specific. One site is in Hayes, so it'll be all Hayes, Kansas partners. We'll do the same thing in Kansas City and Wichita and Topeka and Lawrence. So I just think creating opportunities for students to really like have a voice and say, hey, this is what's important, is a great way to engage people. And, you know, being the champions for their own futures.
Yep, great stuff. Matt, thoughts? We got just about a minute left here.
Sure, I'll try to keep it brief, but I have plenty of thoughts. You know, I think it echoes a conversation I heard at the ASPPH conference a couple of years ago. It's the Schools of Public Health, and they asked the question, like, what are we training our students to do? And they told the story of how Kaiser Permanente opened up a new university in Los Angeles. And USC and UCLA were very upset that the billions of dollars that Kaiser Permanente weren't brought to them. And Kaiser Permanente said, you're training ophthalmologists to think like ophthalmologists. We need ophthalmologists to understand how to navigate the public transit system. And like the difference of interdisciplinary collaboration is not set up within our accreditation system. And our schools are not set up to serve communities. You know, I look at KU Med and they continue to build on the Hill. What would it look like if KU Med said, hey, we're going to invest for 50 years in Quindara Boulevard, and we're going to build up a community land trust and a community kitchen? What would it look like to bring the resources that the university has out into the community? And what kind of pipelines could that create? I'm thinking through, you know, what we did with Dot Agency a couple of years ago. We launched Project Pipeline KC. And we turned it over to the architecture community this year to run it. But we started it with our colleague, a friend of ours from New Orleans, who created the model years ago, and we brought it. And we worked with Community Health Council Wyandotte County and Youth Build KC. And there's a great little video. And I think increasing diversity in the professions only makes the profession stronger. But we're not meeting people where they are. And if you look at how, you know, is there purchasing agreements where our hospitals and our universities are buying within a certain radius of our local economy? Are we locating our, you know, institutions that are going to be, you know, maintained for 100+ years in communities where that is economic vitality for that community? Those are the types of questions. You know, are we paying, are our universities paying property taxes to support the local schools that the kids are going to come through the diversity pipeline to join the profession? Well, if we're not doing that, then how are we talking about increasing equity and increasing the accountability of the work that we're doing? And I think it's one of those things that I get really excited about, how we can, as a university, move the conversation forward, not just locally, but nationally. I think KU can be a visionary at the forefront of that work, but it is going to take kind of breaking through some of the old traditional models that we've allowed ourselves to build up over time, because I think we're in a new world, and how we respond to it is going to be really critical.
Yep, that's great. Well, we're out of time. I just want to say this has been phenomenal. I'm going to make a bunch of med students watch this recording, because there's so many pearls of wisdom in the things the three of you have said today. It's like a mini course in, you know, in participatory community engagement, activism for, you know, for the vulnerable and disadvantaged. So I love it. I'm going to watch it again too. I'm going to make them do it, but this has been really great. I hope our attendees have enjoyed it. We got one comment saying they have, and we hope they'll spread it around. And Michaela will get this recording out to folks, and it can be shared broader to, you know, to all the schools, all the KU campuses. We'll try to reach folks, and like I said, I'll be trying to influence students. So really appreciate all of you, appreciate all the work you do and the thought you put into it, and how much impact you're having, not just in the communities, but with these, like we were just talking about, with these students, because it's so important that it just keeps diffusing out over time. So thanks everyone. We're gonna call it a day and let folks get on with Alumni Weekend. Happy Friday, happy Alumni Weekend. Thanks again to Alumni Affairs. Have a great weekend, everybody.
Thank you,
Thank you.
everyone. This
Thank
was so
you.
profound.
Thank you. Thank you.
Rock chalk.
Rock
Yes, rock
chalk,
chalk.
chaos.
Take care.